Thank you.
Thank you very much, Dr. Hassan. Actually, I think we have a good time for discussion. We will open the floor for questions. May I ask the speakers to come on stage? Okay, I will start the question by asking Dr. Teichmann, what is your selection criteria for implanting toric IOL?
Perfect. Thank you. So my criteria are, the first thing I do, like I said, is I screen to make sure that they're not artifacts or anything that is mimicking astigmatism. And then if I have a patient that has legitimate astigmatism, I look at their what their expectations are, and I look at the amount of astigmatism. I think it's reasonable. I know everyone is going to have a different threshold for what is the minimum amount of astigmatism they implant. I think anyone with over a diopter of astigmatism should be offered a toric IOL, and I think that depending on the axis, some people will suggest even 0.75. Now, there are some people that are very aggressive, in my opinion, and say that everyone should have less than half a diopter of astigmatism, and I think that is ideal. But if you offer, I think the low power toric IOLs are actually a great option. But in my practice, generally I use a cutoff of about 0.75 to 0.1 diopter. 0.75 to 1 diopter as the minimum amount of astigmatism that I will implant a toric IOL for.
So you start implanting the toric IOL if it is 0.75?
Normally
Difference?
not. Normally at 1 diopter, but at 0.75 I start thinking about it. That's the number I see to look for. It depends. You know that people are going to drift against the rule with time. So if someone happens to be 0.75 of against the rule already and they're younger, that's the group that I might consider the 0.75 for a toric IOL. Okay. So, like I said, it's actually a very small group that I would implant at 0.75, but I do start to think about it there. 1 diopter, I do offer it, but I find that a lot of patients, again, depending on, in Canada, there's a lot of things that our government covers most things, but there are things that are additional. Toric IOLs and the calculations, the testing for toric IOLs is all not covered by the government, and it can get expensive if you're doing it for both eyes. So a lot of patients actually, unless they know that they have a decent amount of astigmatism, will actually opt not to have a toric IOL.
Okay.
Good morning, everybody. My first question for Dr. Saad regarding the case which you did it with intracapsular cataract extraction. If you are planning already to do anterior vitrectomy and you have the facility, why you didn't make it, and you are putting also scleral fixation IOL, why you didn't go for a smaller incision to guard against the high astigmatism initiating from this very large incision for the intracapsular cataract extraction?
Then how you remove the whole back with small incision?
Well, you can use the phaco, already you have vitrectomy, but through a smaller incision rather than to be 120 or 100, very large intracapsular incision. And this we are doing before because we don't have the phaco and we have to remove the whole lens, especially if it is a hard lens. But this is a very crystalline lens. Why you didn't go for phaco aspiration? And then already you are planning to do vitrectomy plus putting the scleral lenses through a smaller incision.
So you can even maybe you saw a video by Dr. Ike Ahmed last month. He even a totally dropped lens in the vitreous cavity. He took it up, then he did a lensectomy and he fixed the back. I think it's it's a fancy procedure than a realistic procedure. Of course, I still can go with what you said with the phacoemulsification, but as you can see, there is like most of the vitreous was exposed. So even if you try to remove the lens, you will have some traction on the vitreous. You will have risk of retinal detachment breaks. Especially those cases will be prone to have retinal detachment more than other. So if you try to decrease the manipulation inside the eye, it's better. Although what you said is a choice, of course, but there will be some difficulty with that.
Thank you. For Dr. Hassan Khalid, regarding your technique, what was your parameters in the phaco during removing for this PIX syndrome cases? And do you change the phaco parameters if you are working with small pupil through just sphincterotomies rather than you are doing through Malugin ring? You change the parameters in these two different situations, or they are the same?
Okay, thank you for this nice question. Usually my parameters in almost of my patient vacuum for 150, aspiration 35, battle height 110, infinity machine. Sometimes I work in Centurion. Almost of my patient I use these parameters. Phaco power about 50, torsional 70, sometimes related to the density of the cataract. Sometimes I increase the torsional to 90, 80. Regarding to changing the parameters, it depends on the condition, like patient with photoexfoliation. If there is instability before I do my surgery, while I check my patient in the clinic, always I check the terminus of the iris or phacodonosis. If there is any sign of phacodonosis or iris tremulous, usually I take care about those cases, more care about those cases. I decrease the parameters for those patients. I use the vacuum 300. I also bottle sometimes 90, sometimes 10. I prefer to use phaco chop, horizontal phaco chop on almost of my cases, but in some very dense cataract, I prefer to use stop and chop technique.
Thank you very much.
Welcome.
Question to Dr. Samir regarding the multifocal IOLs. What about the post-operative glare comparison between panoptics and trifocal?
They are almost equal.
Almost equal.
Yes.
Do you know
And
what is the incidence percentage?
It was over 60% in the first month and decreasing by time due to neurosensory adaptation, maybe up to 20%.
Okay. Any more questions? Okay, thank you very much for the speakers, and thank you for all the attendance for attending this session. Okay, thank you.